Hi, this is Lindsay Luther. This is going to be part one of our endocrine conditions. I've broken this section down into several parts. So part one is going to be all of the thyroid conditions. I may actually split this up into a couple of different recordings because the thyroid is probably about 70% of what you'll be tested on, both in APEA and on your boards. So there's several thyroid conditions we see quite frequently in primary care, and I'm going to go through the main ones here. So hypothyroidism, hyperthyroidism, thyroid nodules and how to evaluate and treat them, and then thyroid cancer. So I may split this up a little bit just to make sure that each of those mini areas gets its own due diligence. After that, the 20% of your endocrine-related topics on your boards is probably going to be diabetes, and so I have one short lecture on diabetes and prescribing for diabetes. I will include some additional materials in the supplemental section that you can do if you feel like you need the experience with the diabetes medications. And then we will have a diabetic educator who comes to class to speak to you when you come in for class. So you'll get a little bit more exposure to diabetes there. And then finally, we will hit on the other conditions that are associated with the endocrine system. So these are mostly related to the parathyroid and the adrenal glands at the end part. We'll call it part 3. So this is a little bit of a heavier content area than some of your other modules, just because the endocrine system is a very large system that involves a lot of organs, and it pretty much affects all of your other systems. So one more note is that if you are not super great at understanding how feedback loops work and how the endocrine system is controlled by the hypothalamus and the pituitary gland, then I think it's really important that you please review that before you watch this lecture or any of the other lectures. It's going to be very challenging for you to understand any of this if you don't understand how those feedback loops work. Okay, so let's get started. Okay, so the thyroid, again, we're going to cover 4 main topic areas: hyper, thyroid nodules, and then thyroid cancer. So remember that the thyroid functions on a negative feedback loop. So the hypothalamus produces, the hypothalamus produces hormones which stimulate the pituitary and tell the thyroid gland to produce thyroid hormones. So as the hypothalamus recognizes the need for higher levels of T3 and T4, it will release a hormone called thyrotropin releasing hormone. And this stimulates the anterior pituitary to release a hormone known as TSH, or thyroid stimulating hormone. That TSH then stimulates the thyroid to release T3 and T4. T3 is also called triiodothyronine, so tri being 3, and T4 is also called thyroxine. So T4 makes up about 85% of the hormone that is released by the thyroid. T3 is only about 15%. And then about 99.8% of both T3 and T4 are bound to proteins, and so they are unable to bind to receptor sites in the blood. So only about 0.2% of thyroid hormones are free in the blood and able to bind to the tissues. Free T3, so triiodothyronine, is the active thyroid hormone. So the free form of T3 is the active thyroid hormone. This binds to different tissues in the body and produces metabolic effects. Different tissues of the body require different levels of free T3 to function properly. Free T4 is a non-active version of thyroid hormones, but the tissues can convert it to free T3 for use in appropriate amounts. So when we supplement thyroid hormone with levothyroxine, we're actually supplementing with T4, which the tissues then use to convert to T3 for use. So something that's really important to understand is that it takes a very small change in free T3 and free T4 to make a very large change in the TSH level. So in opposite of that, if there is a teeny tiny change in the TSH level, it doesn't make much of an impact in the actual circulating thyroid hormone levels. So if free T4 decreases from 1 to 0.5, the TSH is going to increase from 0.5 to 50. So that is a huge change in the TSH. However, a TSH rise from 1 to 5 will only reduce the free T4 from 1 to 0.9. So the exact ratio between T3 and T4 free levels and TSH levels is a little bit different from person to person, but it's very static within each individual person as long as there's no disease. So this explains why we use TSH so heavily in monitoring thyroid hormones, because it is a very sensitive marker for changes in homeostasis, because the TSH will change significantly if there's any change in even small change in the free levels of thyroid hormone. So that said, the TSH is not a very good marker for monitoring disease when either the hypothalamus or the pituitary organs are the source of the disease. So, and we'll talk a little bit more about that in a few minutes. So thyroid function test. So TSH will be mildly low anytime a patient has an acute severe illness, and it's mildly elevated during the recovery after a severe illness. So there is a little bit of just physiologic changes to your thyroid function test, which is why we don't typically check them when a person is acutely ill. So the TSH value should be monitored with caution when a person is acutely ill. However, if the TSH is less than 0.1 or if it is more than 10, it is unlikely to be due to just an illness. There are antibodies called heterophile antibodies that are produced after contact with certain animals. So those are called, and that causes a rare condition in which there will be a falsely high TSH result. There's also a rare genetic disorder involving resistance to thyroid hormones. And these patients will present with a goiter, sinus tachycardia, and symptoms of ADHD. And their free T3 and T4 will be elevated, but their TSH is normal. So again, that's called RTH syndrome. It's very uncommon. And then finally, it's possible to have a pituitary adenoma in which it will secrete TSH. And this can look very similar to thyroid hormone resistance. Outside of those very unlikely situations, TSH is the most useful thyroid test. So we use this test because it is the most sensitive to small amounts of changing in the free T3 and T4. So as a primary care provider, you will rarely order more than a TSH. TSH is going to be the thing that you order more than anything. A single abnormal TSH, especially if it's close to normal, especially if it's not too far out of range, is unlikely a good enough reason to diagnose somebody with either hyper or hypothyroidism. And different labs will disagree slightly, and some endocrinologists are pretty strict about what they call a normal or abnormal range. But for your purposes, if you stick with 0.5 to 4.5, and this is a number you should know for your testing, that's what your TSH should be. If you stick with that value, you'll be fine, safe as far as your tests and your boards are concerned. We don't diagnose hypothyroidism until the TSH is closer to over 10. So like we mentioned before, that TSH changes very quickly if there's any kind of significant change in the free T4 or free T3 levels. And so if it's not over 10, then it's probably not significant enough to matter. The TSH has to be significantly greater than normal to treat for hypothyroidism. And we know that especially in older adults, the normal physiologic range is a little bit wider. So probably up until closer to 7 or 8 would be normal for somebody who's an older adult. Actually, we know that adults with low TSHs under 2.5 are more likely to have increased mortality, although we don't technically consider this hyperthyroidism. So the free T3 is not a very useful test in hypothyroidism. We don't use it very often because it is the very last test to become abnormal. So we avoid using that test in hypothyroidism. We use it a little bit more in hyperthyroidism. Okay, so let's go ahead and get into the nitty-gritty of these tests. So you can call euthyroid 0.5 to 4.5, so normal thyroid. It is one of the tests that we can do for thyroid dysfunction is an anti-TPO antibody, so anti-thyroperoxidase antibody. And this signifies that the immune system is reacting to the thyroid in a negative way. It is possible for somebody to have positive antibodies and not have a thyroid issue. So you can have those antibodies without it doing enough damage to cause a problem with the thyroid's function. So if a patient's euthyroid, they should have a normal free T4 and free T3, and they should not have any symptoms. Subclinical hypothyroidism, they will have a value between 4.6 and 10. Their free T4 and free T3 are still in the normal ranges. Remember that TSH has to change a lot for those to change. It's possible for them to have those antibodies, and they may report some symptoms, but typically we don't buy into the symptoms too much because, again, their thyroid hormone levels are still normal. Overt hypothyroidism is any time the TSH is over 10. So their thyroid hormone levels will likely be low. Their free T3 may actually be pretty normal at this point, and it will not get low until there's significant disease. It is common for there to be antibodies to the thyroid, and it's common for there to be symptoms. The most typical cause of overt hypothyroidism is Hashimoto thyroiditis, and Hashimoto's is an autoimmune disorder, so it's likely that there will be antibodies. There is a subclinical hyperthyroidism, although because this range is a lot smaller, it's not very common to see it because typically people don't present until they are in overt hyperthyroidism. Probably the population you would catch it in the most is pregnant patients because we screen them. They're one of the only people that we should really be screening. So they may have antibodies as well. This could signify either an autoimmune or a Graves type disease and hyperthyroidism. In order to diagnose overt hypothyroidism, you're going to go with a TSH under 0.1. Their T3 and T4 free levels will be high, and they are likely to have symptoms. And then just as one more comment, we have a much narrower range for thyroid function in pregnancy. So if you have a pregnant patient, so all these values are for patients who are not pregnant because we are a little bit tighter with our ranges for patients who are pregnant. Okay. Subclinical hypothyroidism. So it's very difficult to tell whether or not subclinical hypothyroidism causes symptoms or not because most of the symptoms are pretty vague and pretty benign on their own. So things like fatigue or weight gain, a lot of things can cause those. So it's hard to tell if the symptoms are really associated with the TSH and free T4 level. So you'll know you have a subclinical hypothyroidism when the TSH is mildly elevated, but their free T4 is still normal. The prevalence is about 4 to 9% of the population. Most of these patients should just be reassessed every 6 to 12 months. The reason is that about half of them will return to normal function, and only about 5 to 6% will convert to overt hypothyroidism. The rest will remain in the subclinical phase or in the subclinical diagnostic range. If they have anti-TPO antibodies, that increases the risk of overt hypothyroidism, but not by very much. It's not enough to predict who will and who will not end up converting to overt hypothyroidism. Some providers will offer a 3-month trial of low-dose levothyroxine in order to treat symptoms, but this is not an evidence-based practice approach. The best option is watchful waiting as long as the TSH remains under 10 and the patient is not pregnant. Patients who have abnormal antibodies or serum lipid levels, or if the patient smokes, may may alter the TSH as well. So cigarettes contain cyanide, and in the body this is converted to a chemical called thiocyanate, and thiocyanate impairs the uptake of iodine by the thyroid, which impairs thyroid hormone synthesis, and it also increases how much iodine is excreted by the kidneys. So this can cause a small reduction in thyroid hormone levels and lead to an elevated TSH. And tobacco overall just increases inflammation, and so this can contribute to and hasten the destructiveness of autoimmune processes like Hashimoto's and Graves' disease. So if you have a patient who's a subclinical hypothyroidism who smokes, getting them to quit smoking can actually be really helpful. So I know that you are all familiar with the signs and symptoms of hypo and hyperthyroidism. They are pretty much opposition to one another, so it's helpful if you can keep in mind that when you're studying, it'll help you to remember what is hypo and what is hyper. So hypothyroidism, in terms of overt hypothyroidism, have a failure of the feedback loop between their hypothalamus, the pituitary, and the thyroid. So who gets it and why? Typically, patients with hypothyroidism are more likely to be female, 2 to 8 times more likely to be female than male. The most common race is Caucasian. Autoimmune processes are the primary causes in the United States, and internationally it's more likely to be related to iodine deficiency. It can be congenital. However, we include this as part of our newborn screenings. So if a patient does have a congenital hypothyroidism, they should know it before they get to your office. I do have a case study that we can talk about that I can post for you to view as an optional case study. There's some questions, I believe, and one of them is related to congenital hypothyroidism, so that's something you could think about. We can also cause hypothyroidism as a result of our treatment, so especially if a patient has hyperthyroidism and we treat them with radioactive iodine, or if a patient has a thyroid goiter that's very large, or a thyroid cancer, and we remove the thyroid, we can cause a hypothyroidism. That's called iatrogenic. So we screen for hypothyroidism very rarely. The only times we really screen these patients for hypothyroidism is if they are symptomatic, so they have symptoms consistent with it. If they have a concurrent autoimmune disease or a history of head and neck radiation, if they've previously been treated for hypothyroidism, if they have a family history, or if they use drugs that can cause hypothyroidism. So some of those drugs include lithium, amiodarone, interferon alpha, interleukin 2, and tyrosine kinase inhibitors. Most of your patients are not on those drugs with the exception of amiodarone and maybe lithium. You will see a lot of patients on amiodarone, and if they have not been, they need to be screened for hypothyroidism. So there are several different types, as we talked about before. There's actually many, many, many types, but the ones that you're going to see the most in practice are Hashimoto's thyroiditis, which is a form of primary hypothyroidism, so it's a failure of the actual thyroid. It is the most common form of autoimmune thyroid disease, and it typically occurs in women between the ages of 30 and 60. Iatrogenic hypothyroidism we talked about a little bit, but it's usually secondary to drugs, radioactive iodine, or surgery. Secondary hypothyroidism is caused by a failure of the pituitary. So if the pituitary will not secrete enough TSH, then the thyroid doesn't know that it needs to make thyroid hormone. And then finally, tertiary hypothyroidism is a failure of the hypothalamus to secrete thyrotropin-releasing hormone, or a failure of the TRH to activate its receptors in the pituitary. That's called peripheral resistance. There is a type of hypothyroidism called central hypothyroidism, and this is a failure of the pituitary, and it's related to the presence of a tumor infiltrating into the pituitary and preventing it from stimulating, or into the hypothalamus and preventing it from stimulating properly in that feedback loop. So we've already talked about the pathophysiology, but there's several mechanisms which can contribute to hypothyroidism. There can either be a loss of the functional tissue of the thyroid, or alterations in the thyroid hormone production, or there can be a failure of the two stimulating bodies, which are the pituitary and the hypothalamus. We have talked a little bit about some of the other causes. Basically, though, something that you need to understand is that the thyroid hormone is really essential for normal growth and development, for the synthesis of proteins, and for cell metabolism. And this is true both in fetal development and after birth and into adulthood. So across the world, iodine deficiency is the primary cause of hypothyroidism, because iodine is a necessary component of thyroid hormones. So without it, we can't even create thyroid hormones for use in the body. So what happens is that when your T4 production, your free T4 production, is not adequate, the thyroid gland starts to enlarge, and this results in hypertrophy and hyperplasia of the gland cells, and this causes a goiter. Initially, there will be increased conversion of T4 to T3 in an attempt to compensate for the lack of free hormones that are circulating. So in Hashimoto's thyroiditis, which is the most common type of autoimmune thyroiditis, the body pathologically recognizes thyroid antigens as foreign, and this leads to a chronic immune response against the tissue of the thyroid gland, and eventually this causes atrophy of the follicles. The follicles are what create the thyroid hormone within the thyroid. This Hashimoto's frequently begins after a viral infection, because the antibodies that are produced against the virus become sensitized against the host thyroid, and then it attacks the body's own cells. And inflammatory thyroiditis can also be caused by an immune cross-reactivity following a viral infection, but these tend to be pretty short-lived. And we typically classify these as painful or subacute thyroiditis. There's also a form of thyroiditis called lymphocytic, and this causes a transient hypothyroidism in about 10% of postpartum women. Central hypothyroidism we already talked about, and that's from tumors that are pressing on the hypothalamus or the pituitary, or it can also result from radiation of the brain. The most common cause of iatrogenic hypothyroidism we mentioned was use of radioactive iodine or surgery to remove the thyroid gland for either hyperthyroidism or for a thyroid cancer. So as the thyroid fails, the metabolic rate of the body reduces, and this impairs lipid metabolism, slows gastric emptying, and also causes other endocrine abnormalities such as changes in fertility, insulin resistance, and impaired production of red blood cells. This results in menstrual irregularities, infertility, delayed onset of puberty, insulin resistance, and decreased erythropoiesis. There is also an accumulation of hydrophilic proteoglycans in the interstitial spaces of the whole body, and this causes many of the characteristic features of hypothyroidism, including pleural, cardiac, and peritoneal effusions, the myxomatous edema, and cardiac hypertrophy. So I think you guys are all pretty aware of the clinical presentation of hypothyroidism. It will vary depending on the age at onset. So if it's occurring in children and teens, you may see a delay of puberty as one of the primary symptoms. Whereas in older adults, it may be a little bit harder to pick out, because a lot of the things that we consider normal in older adults, like constipation and fatigue and feeling cold, it's hard to tease that out from the signs of hypothyroidism. So there's a long list here in the presentation notes of the various symptoms, but I think it's important that you understand and be able to pick out the clinical picture of hypothyroidism. So make sure that you review those. So we talked a little bit before about diagnostic testing. The initial testing is going to be a TSH level and a free T4 level. So just those two tests. You do not need to add a T3 level to that test, because as we said before, that'll be the last one to change, and so it's not very sensitive and it's not very significant, because you'll already know there's a problem from the free T4 level. So the general principle that you need to consider is that the TSH level will tell you where the deficiency is coming from. So the TSH level tells you if the feedback loop is working. The free T4 level tells you that there is a hypothyroidism. So if the hypothyroidism is coming from a failure of the thyroid, we call that primary hypothyroidism. This is what we expect to see when we do our testing. So in this situation, the free T4 is low because the thyroid cannot produce enough thyroid hormone. The TSH becomes high because the pituitary is working harder to try to stimulate the thyroid to do what it's supposed to do. So when your TSH is high and your free T4 is low, that means that the thyroid is failing, and this can pretty much be managed in primary care. Probably 95 times out of 100, this is what you're going to see. It is possible that the hypothyroidism that your patient has is a central hypothyroidism. So central hypothyroidism is a little bit tricky. Your free T4 level will be low. That's how you know it's hypo. But your TSH level could either be low, normal, or just off. So it could be elevated but not elevated enough, as what you would expect. So this means that your feedback loop is not working. If this is true, if your feedback loop has failed, then you probably are going to refer them to endocrinology. So primary hypothyroidism can be managed in primary care. Central hypothyroidism should be referred to endocrinology just to get that initial diagnostic testing done and figure out what exactly the cause is. And then you may or may not get that patient back to come to you for management. So after you've done your diagnostic testing, you need to make sure that, so now that you know that they have hypothyroidism and probably primary hypothyroidism, your goal is to determine how much impact the disease is having. So you're going to order additional tests based on your clinical concerns. So if you're concerned about impaired erythropoiesis, you're going to check their CBC for their H&H. If you're worried about lipid dysfunction, you're going to check their lipid levels and LFTs. If you're worried about renal disease, you're going to check a BMP to make sure that their kidney function is adequate. If you're worried about heart failure, you may check a chest x-ray. If you're worried about infiltrative issues with the cardiac system or electrolyte abnormalities, you might check an EKG. UA can be helpful if you think that they have diabetes or if you have concern for other infection. So the idea is that you want to rule out any concerns that need to be addressed or identify any concerns that need to be addressed. And then if you suspect Hashimoto's disease or Hashimoto's thyroiditis, you can check those anti-TPO antibodies. Some labs will have this called antimicrosomal antibody. If you get a titer of 1 to 400, that is diagnostic for Hashimoto's. And then if you see nodules in association with the hypothyroidism, then the patient needs to have an ultrasound. And we'll get all into thyroid nodules in a little bit. So your differential diagnosis is going to depend on the presenting symptom. So the things that you really need to rule out first is the patient acutely ill? Do they have a psychiatric disorder and that this is a manifestation of the psychiatric disorder? Or are there non-thyroid disorders that cause similar symptoms? So the differential is not huge on this. However, as you saw, like with our women's health case study in class, sometimes we see dysfunctions of other organ systems like heavy menstrual bleeding, and we need to figure out if that is hypothyroidism. Typically, hypothyroidism is not your first thing unless the patient's coming in with vague symptoms like that, fatigue and weight gain and dry skin and stuff like that. So management of hypothyroidism is actually really easy because there's really only one drug we can use, and that drug is levothyroxine. So levothyroxine is the synthetic version of T4. We treat hypothyroidism with T4 primarily because, and not with T3, because the half-life of T3 is very short, and so it has to be dosed multiple times a day. So T4 is converted to T3 by the peripheral tissues. There is a couple of alternatives. You can supplement with T3, but I would not do it as a primary care provider. If you think your patient has an issue such as an issue converting their T4 to T3, or if they have an issue with peripheral insensitivity to thyroid hormone, then that is above your level of expertise, and they probably need to be going somewhere else to get that managed. There are some bioidentical thyroid hormones, such as Armour thyroid, and most endocrinologists and endocrine societies recommend against these for several reasons. Those reasons being that compounding pharmacies may or may not be very well regulated. Most FDA-approved hormones are sophisticated enough that they are considered bioidentical, or they're made of the same chemical and molecular structure as human hormones anyway. And there's debate about this debate about bioidenticals is really a much bigger debate when we're talking about menopausal therapy, but you do need to know that some patients will be on Armour thyroid, and the dosing is different than it is for levothyroxine. So normally our goal is to normalize the TSH when we're managing with levothyroxine. So the best way to start, you're eventually going to get the patient up to about 1.6 micrograms per kilogram per day, but you need to start very low and go slow. So if a patient is older or has any level of heart disease, you want to start them very low at 25 micrograms per day. And thyroid hormone T4 has an incredibly long half-life, so it takes about 6 weeks to get the full effects of the drug. So for adults who don't have any risk factors, we can start a little bit higher, younger adults, around 50 micrograms a day, and again, we're going to increase every 4 to 6 weeks. Patients need to take this in the morning with a full glass of water and no other medications, and ideally they should take an hour to let it absorb before they start eating. So it's helpful to have patients keep this by their bedside, take it when they first wake up in the morning, then they can get up, shower, brush their teeth, get ready for work, and then they can go eat breakfast. The goal is for the TSH to stay in the range of 0.3 to 3, give or take. One thing that's really important is that you want to make sure that the prescription does not allow substitution. So if you're going to give them a generic form of thyroid medication, it needs to be the same generic medication every time they fill it. And that's a real challenge. So most of the time this is probably the only situation where the brand name actually makes a difference. And it's because the different elements of the pill will change the way that it's absorbed, and thyroid hormone, as we mentioned, with the way that it has to be taken very specifically, it does not absorb very well. Different pills will absorb a little bit better, a little bit worse than others, and so it just needs to be consistent because we need to make sure that their dose is getting them to the right TSH levels. So we are going to check on these patients every 4 to 6 weeks until we get them to a stable level by redrawing their TSH levels and adjusting their dose based on the TSH level. If they have any other conditions developed during that time, such as pregnancy or illness or weight change, that is going to affect the dose and will continue to affect the dose throughout the time they're on this medication, which is typically the rest of their life, although not always. So once they're stable, we will still check their TSH every 6 months to a year. This is a very high yield question on your board, so just know this. There is no reason to check a free T4 or a free T3 when your TSH is within a normal range, except for on diagnosis. So we initially check the free T4 with the TSH to make sure that they are indeed hypothyroidism and that we're not having a central hypothyroidism. But once we've established that they are hypothyroid, and that this is a primary hypothyroidism, we can monitor with the TSH. The only other situation in which you may go back and check the free T4 is if your TSH just does not correlate with the clinical picture. So when should you refer to endocrinology? If your testing levels do not correlate with the clinical picture, that's a really good reason. If you think the patient has a central hypothyroidism or is showing symptoms of myxedema, has chest pain, new cardiac disease, or thyrotoxicosis, then that's a reason to refer to endocrinology and probably to cardiology as well. Any patient who has a severe illness or confusing laboratory results should be referred. Children should be referred for their initial consultation, and pregnant and postpartum patients may need to be referred as well. Any patients taking lithium or amiodarone should be referred, and this should be consideration for the cardiology or for behavioral health, whoever's managing that. And then obviously we're going to provide these patients with education about diet, prevention of constipation, the need for lifelong therapy and follow-up. They also need to be taught to recognize the signs of thyrotoxicosis, angina, and arrhythmias. So the last thing we're going to talk about with hypothyroidism is myxedema coma. This is a very unlikely, very rare, about 1 in 5 million people per year, condition that occurs typically amongst patients who live in remote areas where iodine deficiency is endemic. But in those areas, it's probably more common than we know about. So you need to have a high rate of suspicion in any patient who presents for emergent care and has decreasing responsiveness, particularly if they have a history of uncontrolled hypothyroidism, a history of radioactive iodine treatment, or a surgical thyroidectomy. Typically, these patients will have had a precipitating significant health event. They will show decreased mental status, hypothermia, and slowed organ function. If you think that this is what it is, you need to treat them right away. We typically do not wait for the lab results, which can take several hours. The mortality is 25 to 60%, even with ideal treatment, so it is very important to get them started on treatment. These patients will get thyroid hormones IV and glucocorticoids until we're sure that they don't also have an adrenal insufficiency, and they get supportive measures. And typically these patients have a lot of health issues, so they're going to need management of those current conditions. The supportive measures that you'll use may include ICU admission, mechanical ventilation. They may need hyponatremia correction, passive rewarming, and empiric antibiotic therapy if infection is thought to be the precipitating event. So you can see this photo is from a case study in the New England Journal of Medicine showing a patient who presented in myxedema coma and then how she looked after she recovered. Okay, so I'm going to go ahead and bring this to a close right now, and we will start with the next section on hyperthyroidism in a separate presentation.